All right, let's get started.
Hi there. We're going to talk today about orofacial myofunctional disorders in your patient and your faces. So before we start, we're going to I'd like you to download the WhatsApp app for a little activity we're going to do later. So take a minute or two to do that. And then we're just going to jump right in to talk about what patients are in your chair daily. We have patients that, our first patient is that patient with the super strong tongue, pushing your mirror away, pushing your scalers away, getting involved all in what you're trying to do while you're cleaning their lower anterior teeth. And so I know you have those patients in your chair every day. Next. And we also have our patient who's scared and protective, gagging on everything, having trouble just even laying there and trying to relax, and they're protecting their airway. And I know you have those patients in your chair as well. Well, this is all connected. Also, the other patients that we may have are patients who are getting recurrent decay all the time. They are having trouble with they're keeping their teeth clean. They have gingivitis every time they come in. And it's all connected. My name is Suzanne Robertson, and I'm a myofunctional therapist in La Jolla, California.
And I am Shirley Gutkowski, and I am a myofunctional therapist in Madison, Wisconsin.
So what we're talking about here is orofacial myofunctional disorders. It's a big, long word, but this is kind of a breakdown on what the definition is, and it'll help you to understand what we're doing. And these are disorders that affect the face and the whole body. It affects nursing, swallowing, could cause anxiety, blood pressure, brain development, respiration, occlusion.
We like to talk about occlusion a little bit because most people would say that this looks great. And we're going to explore why this isn't necessarily so great. It depends on the age of the child. So we also talk about arch form quite a bit because this is not something that we think about all the time. You may think that this looks fantastic, but when you look at this arch form over here on the right, you will notice that it is very deep and very narrow in here, and the alveolar ridge is very wide. And this is dysfunctional. And if it's not addressed early in a pediatric patient, then it turns into a patient who is an adult with these kind of problems. And as we go through, we're going to talk about why that's problematic. This person here has a pretty good arch form. The alveolar ridge isn't very wide. It's kind of broad and low. It looks pretty good, but this isn't the only thing that we look at. We also want to be sure to look in the airway. We used to call it the throat. Does everybody remember the throat? I graduated in 1986, and that's all we had was a throat. And it wasn't until 2014 that I was exposed to the term airway. And I don't know, we always talk about airway in emergencies, and you see, but you know, they were intubating people and blah, blah, blah. I never really considered it as part of our even interest. And so really this is the key, is making sure that we're using the correct terms. And this is now known as the airway. You can see this person here has what you would consider a very long tongue. But look how wide it is back here, how long the tongue is from the back, and how hyperextended that is. You can't really see, it's a little bit fuzzy here, but in the left-hand photo, you can't really see the uvula, and the tongue is resting kind of high. And when you look at her arch form, you would see that her frenum, her lingual frenum, is attached almost onto the mandible. We can think of the tongue as a respiratory organ. That was a term that was just brought up this past summer in a course. And as we go through, we'll kind of explore why we can even think of it that way.
So here are 3 different types of tongues and tongue tips. We have our first one has a kind of a blunted tip, and the middle one is pointed, and the last one is flat. We look at the tongue, all the details of what could be going on and what all this means.
And with those kind of issues, if they're not brought on early, we end up with these kind of issues later on in life, where this person has a restricted tongue. You can see, if you use your imagination just a tiny bit, you can tell that all of these teeth are restored, and they've been restored at least 3 times. The tongue does not come out. It looks battered and used up. All of the upper teeth were also all restored numerous times. And because of that, we see this happening. This is a torus. If you all remember torus, remember that? In 1986, when I graduated from my program, the torus was idiopathic. Nobody knew where it came from. It just happened. Today, we know it to be a growth that occurs from bruxing, and the lower tori come from this tie. Can you see here how the tie is how the frenum is attached very far forward? If you looked at this floor of the mouth with the tip of the tongue up against the roof of the mouth, you will see all kinds of tissue pulling against these toral bones, bony growths. So we need to get to these children. We need to get to the pediatric patient as soon as possible, if not sooner. Now, we just had a course this morning, and they were questioning the torus, and I'm going to just go off script here for a little bit, Suzanne, because this was a very interesting point that I thought was new. The tongue needs to rest against the palate, and that interaction between the neurology of the tongue and the neurology of the palate needs to occur. If it doesn't occur, the current inquiry is to whether or not that maxillary torus is there as a function of bringing the palate down lower so that the tongue could touch it, which is a really weird kind of a way of looking at it. And I love it because I think it's probably the best answer that we've had so far.
Yeah, sure. It's like the body saying, hey, we gotta connect here. Kind of like the lips too.
Yeah, exactly.
A myofunctional therapy is a program that addresses the muscles in the snoring complex, also known as the craniofacial respiratory complex. So we also need to look at noxious habits, nail biting, thumb sucking, overuse of pacifier. All these are, and grinding your teeth at night. These are all ways to open up the airway. Our brain is saying we need to breathe more. So by grinding our teeth or putting our thumb in our mouth, it's bringing our lower jaw forward to open up the airway. Does that make sense?
And not only that, we think of these habits as being habitual, but they're really a cry for another solution, like the torus growing. The thumb is there to touch the roof of the mouth and stimulate the neurology up there. The teeth are grinding in children because they're trying to move their jaw forward so that they can breathe easier. There's no child that is that stressed that they're going to grind their teeth in the United States unless they live in the third world country part of the United States.
Right. And back to that also, you know, we learned that grinding your teeth was just because it was from stress and anxiety. And so we know now it isn't. So this is our competition. This is just a very dramatic slide of what an orthodontist would do possibly for a tongue thrust, or put that tongue toy in, or the cage where to keep the tongue from thrusting outward. The tongue is trying to thrust outward so it can open up that airway, make more space in there so the patient can breathe better. And our medical profession, this is their answer to sleep problems, sleep apnea, a CPAP machine. And this infant's face, this elastic goes around the face, and in the adult, it goes around the man's neck. This is actually, if one had to wear this for more than, which they would have to wear for a lifetime, this is actually pushing the lower jaw in and back. So this is actually making the airway worse.
And this is what they call the gold standard. It's so far from any physiological answer that it's just getting harder and harder to say.
Right. So neurological effects may be irreversible on kids that have sleep disordered breathing. And because they have problematic behaviors like ADHD, ADD, kids that are diagnosed with ADD and ADHD, I just was looking at a paper, it goes from 25% to 80% of kids that are diagnosed with ADHD or ADD actually have sleep disordered breathing problems.
And it's expensive. These are 2007 numbers. $42 billion are spent on problems with societal problems in children and adolescents. That's huge. That's huge. And then as we go forward, you know, it's not going down. I don't know about you guys, but it's almost to the point where every child is on some kind of medication for something. And there are a lot of problems with these medications. They may seem to calm the child down, but it's not helpful for these children to learn how to monitor themselves and how to regulate their emotions by using medications. When almost 50% of it's over that, 50% of children who have extended enuresis, who are bedwetting, have sleep disordered breathing. And for ADHD, it's even higher.
So what do you see in your own mouth? Let's take a look in your mouth.
You might want to get a mirror or something like that.
Or you can use your phone, your camera on your phone. So what we're going to have you do is I'm going to have you open your mouth as wide as you can. Okay. Then you're going to put the tip of your tongue up onto the incisive papilla. And if your mouth closes more than 50% when you do that, there's a possibility that you may have a tongue restriction or a tongue tie or a restricted frenulum.
So this person was able to lift their tongue to the spot behind their upper front teeth, the incisive papilla, but there's not more than 50% closing in this little test. So this is a pretty quick and easy kind of a thing that you can do during your oral cancer screening. No problema. Now, go ahead.
So in this patient, the mouth is open and the tongue is up, but we can also look at other things. We can look at that string or that frenulum and see if it looks short or tight, or we see here in this picture, the floor of the mouth is lifting. So we look for all those things. In order to get that tongue up, this patient has to lift the whole floor of the mouth. So if you put your finger down where that attachment is and toward the floor of the mouth, you'll actually get the proper measurement and see that this patient is restricted. Just a little side note here as well. Look at the nostrils on this patient. Do you think this patient's a nose breather or a mouth breather? It looks like they have hardly any openings there to breathe through their nose.
So what are you seeing in there? So we're going to ask you to send us your photos, and then we'll give you a tiny little assessment when we look at the pictures after our course. And I ask you to send us 3 pictures, one where you're opening comfortably wide, one with the tongue up to the spot behind your upper front teeth, and one with this suction. So the suction is a little bit tricky, and not everyone can even do that. And if you send that to my WhatsApp at this phone number here, that would be super sweet. And Philip will get in touch with you and talk to you about a really deep discount that we're offering, that Suzanne and I are offering.
So let's try and see if you can actually do the suction maneuver. So what I like to say is I have the patient lay their whole tongue up on the palate as best they can. And then you want to make like a click sound. But before you make the sound, you suck your tongue up onto the palate. And you may be able to get part of your tongue up there. You may be able to get only one part of the tongue. You may see the whole floor of the mouth lifting. You may see the overflow of the tongue onto your teeth. So there's many variations of the suction maneuver that you're going to see. So here's an example. And then we'd like to know, or maybe
the first picture will show us.
Yes. So what is your airway score? So this is the Mallampati for those of you guys that aren't familiar with that. And the one below is the Friedman score. So for the Mallampati, what you do is you stick your tongue out, open your mouth, stick your tongue out. And we're trying to see how much of the uvula and the back of the airway we can see. So obviously number 1 is all open and toned, and we can see the full uvula. And number 4, all we see is soft palate. All we see is a soft palate and no part of the uvula. And number 2 and 3 are somewhere there in the middle. For the Friedman score, it's the tongue is inside the mouth and how much you can lift that uvula and see it. Obviously, number 1, same thing. Number 4, no uvula at all in sight.
So these tests are done without phonation. That means you're not saying ah. And it's just an opening of the mouth. And I don't know about you, Suzanne, but when I first learned about this, I was like, oh, nobody's going to be a class 4. I'm never going to see that. These are dead people. These are people that are in the hospital. And I can't get over how many people, young and old, have no airway. And right. Like I said, if you don't call it an airway, if you just call it a throat, it's not a big deal. But if you call it an airway, suddenly the deal gets much, much bigger.
Makes so much sense. And then we have our tonsil score. So number 1 would be how much tonsillar tissue can you see, as opposed to number 4, where they're kissing tonsils, you can't see that airway at all. So number 3 and 4, we like to refer for an ENT evaluation because those tonsils are taking up that space in the airway.
The book Breath came out this summer, and it's just been shaking up the whole world, it seems to me, because I have an interest in it. And you can see James Nestor, the author of this book, across every podcast, across every health podcast that there is. It's really just amazing how many people are so enamored with what he was talking about, because everybody thinks that they can breathe. Oh, I can breathe, no problem. But breathing correctly can be a big problem, as we're learning from our colleagues in anthropology. We are noticing that the face is smaller and that there's less airway. Remember when I showed you the picture of that really vaulted palate in that girl with straight teeth? That goes right up into the palate goes right up into her maxillary sinuses. So we're in a position now where everything is getting shut down and we're forced to do mouth breathing.
So first of all, this is one of my little patients. He is a mouth breather, obviously. He's got the large rolled lips. His tongue doesn't touch the palate because he's actually was tongue-tied. His mom's a dentist. Not a lot of knowledge of all this. So we're working with him with myofunctional therapy and mouth breathing. But what I would like for you to do is just open your mouth and put your tongue low and try to breathe for 30 seconds in and out through your mouth. I know when I try to do that, it feels really icky and my mouth feels so gross and dry. And it's just very not a good feeling. It dries out the tissues. The habit, then you're unable to breathe through your nose at all. The nose becomes congested and the patient, the child, adult is just 100% mouth breather.
I was a mouth breather most of my life, and I remember having nightmares about insects crawling into my mouth. And it took me a while to kind of remember that. No one ever said to me, Shirley, you should breathe with your mouth closed or anything like that. It's just been a crazy learning experience. And I'm hoping that people who graduated in the last 5 or 10 years have a little bit more background in this kind of thing. We were told if we saw the gingiva red, we were to say to our patients, do you breathe with your mouth open? And if they were to say yes, which nobody knows they're breathing with their mouth open, we were to say, close your mouth. That was pretty much it. That was it. I don't remember her saying, send the patient to an ENT or that there may be an ENT referral, and maybe I blocked that out, but.
Well, Shirley, I was going to say my next thing would be trying to talk to the ENTs after they do their nasal surgery to refer to us to teach how to breathe through the nose once they repair the nose and the patient can breathe through it.
Excellent. So we're going to do a poll. Here's poll number 1. Poll question. Oh, they're both at the same time. How many patients do you think are mouth breathing? 1 a day, less than 1 period? You don't have any idea? Let's just go by a day or a week. How many patients do you think are breathing improperly? In a study that was released in 2012, oh my gosh, I think it was 8,000 people. It was Karen Bonnick. And the researchers concluded that children that make any sound during breathing at all have a high risk of having ADHD and learning disabilities. It was like in the 80%. So wow. Getting to this early is really, really important. Well, we've got 76% of the votes are in. So over half, a lot of people are thinking that, oh, let's see, if I close it and then I share results, you can see. Maxillary dysmorphia. I had to dig that one out. So you're right. All 3 of these happen when you breathe through your mouth. And it's pretty damaging for everything. The maxillary sinuses don't grow. We have a number of studies that show that the mouth breathing patients or patients that don't use their nose to breathe have stunted growth. So imagine me now, and now that I'm over 29, and let's say that I have the sinuses of a 12-year-old since they stopped growing, I didn't use it, so just went into atrophy.
Can you unshare the poll, or the poll is still up?
The poll is still up?
Well, on my screen it is. Somebody let us know if the poll is still up on your screen.
You hit the close button and it'll close.
I did hit the close button.
There we
Huh,
go.
I just hit the close button at
There we
the
go.
top left of the poll and it closed.
Oh, you closed your own poll?
Yeah.
Sweet.
Thank you.
So here we are with these tiny sinuses, and we're asking people to breathe through their nose. We also know that mouth breathing children, 87% of those with mouth breathing had hypertrophied adenoids. They had maxillary sinusitis. They have pneumatized middle concha, which is the concha in the sinuses. Deviated septum. Did you ever talk to anybody that had an idiopathic deviated septum? That's because there's a mismatch in the growth of this part of the face over the middle part of the face. And when there's a mismatch, that little cartilage that's separating the two sides of your nose can crimp. And that is where you get that idiopathic, non-traumatic deviated septum. This was also a pretty important study that looked at mouth breathing and malocclusion. And the malocclusion is across the board. It's the gambit. Who would know that all of these things were caused by mouth breathing? It just depends on how you compensate for non-nasal breathing.
So these things, they just don't go away. Children with myofunctional disorders turn into adults with myofunctional disorders. The body compensates and changes, things go away, and then something else shows up. And then these are your adult patients, if you have adult patients, who are having broken teeth or root canals all the time. Just doesn't go away.
It's continually worse and worse. This patient, I'm not saying this happens to everybody, multiple strokes in the last 2 years. And multiple health problems and vasculitis, cerebral vasculitis. Who ever heard of that? It just goes on and on. This person has never been able to breathe correctly.
So why should we care about this? Because when the normal patterns of growth are interrupted, we get more dysfunction, more malocclusion, craniofacial growth and development. The kids' faces look like mouth breathing faces, long, narrow faces. Do we want that? So the tongue is one of the strongest muscles in the body. And so if the tongue is pushing on the palate, it's able to make that palate that's high and narrow to be flatter and wider, which actually we were talking about sinuses and nasal space. The palate is the floor of the nose. So if you have a high, narrow, vaulted palate, it cuts into that nasal breathing space. And you talk about the septum, it can actually make that septum crooked. So to tongue tie again. So, this is a very obvious tongue tie, the heart-shaped tongue, but I want you to try to, again, glue your tongue down to the floor of your mouth, and it's going to probably force you to mouth breathe. It's going to, a lot of kids have speech issues. The tongue cannot move properly because it's tethered down. Also, cleaning interproximal, your natural cleaning that your tongue does in between your teeth after you eat and in the vestibules, this cannot be done because of a tongue restriction.
And we have a really low bar for tongue tie in dentistry. How is it that these people grew up to be old enough to wear a beard and they still have their tongue tied like that? This is going to be a really big problem. When I started my practice, I was like, wow, does everybody have a tongue tie? Did you have the same thing, Suzanne?
Yes. I find that the patients that end up coming to us because of the missing link or piece that they can't figure out, most of them are tongue-tied because that's where they're getting all these symptoms from.
It's really unbelievable. these people have a bunch of dysfunction. I just stole these from what do you call it, Google Images. So I don't have any relationship with these two pictures, but you just have to wonder, they come in for this is what happened to me after I took my first class. I'm subbing at a dental office. I call the doctor in and I say, wow, he's got a pretty severe tongue tie. It was much like one of these two. And the doctor goes, well, he looked at the patient, noticed that the patient was Wisconsin size, for you people that know what that means. He was a little bit heavy. And he goes, well, looks like you can eat and looks like you can talk. So I guess it's just going to be fine. And today, I mean, look at, where's his airway in this person,
Right.
We have to be more quick to get to this problem and solve it.
And so if this were true, why didn't we learn this in dental hygiene school? I mean, I didn't learn anything about this. But luckily for us, the last 10 years, there are so many articles on PubMed and different articles and research done on mouth breathing and orofacial myofunctional therapy.
This was just a search on PubMed on mouth breathing and tonsils. And, 2019, there were a couple from 2020 in there. And just they're looking at the growth of people who breathe with their mouth open, children in particular, and the relationship between maximum tongue, what is that? Oh, I got to move my little pictures here. Tongue pressure and mouth breathing and what all comes out of that. We have to also be more aware of non-American research. We can be more tolerant of other countries. In Brazil, you may know that they have a law where all newborns are tested for tongue tie before they leave the hospital. So that's probably, is it 5 or 6 years now that's been going on? And so we'd probably be expecting some kind of research based off of those findings pretty soon.
Yeah, Brazil's pretty far ahead in myofunctional disorders and screening.
So this is where we would start, the craniofacial respiratory complex. Now we used that term earlier. And we don't think of the respiratory piece of this when we're talking about dentistry and dental hygiene. We're always talking about craniofacial, but we can't really separate this sinus part, the breathing part, the anterior and superior respiratory area, the respiratory complex. So start using this term, craniofacial respiratory complex, to really get the whole picture of how this all goes.
So what can we do? We start with early intervention, okay? So that is like we talked about in Brazil. They do the check of the frenum when the child is born. They follow the patient with lactation specialists, and that's what we can do. Have a lactation specialist if a pediatrician doesn't agree or think it's a tongue tie. A lot of pediatricians are not well versed in tongue tie unless it's super obvious, but there are other ones. We go a lot of the time by symptoms. So early intervention would be a good screening, okay, for nursing and latching and sucking. The next thing would be introduce whole foods, limit pacifier use and bottle use, and limit those containers, having the baby sit in the containers all day long. Kids mirror their parents, and a lot of this is a genetic thing. If the mother or father has a tongue tie, the child usually does. They say sometimes, oh, well, I got the big teeth from my dad and the small teeth from my mom. This is all, it's all because of the tongue is not able to get to the palate to help to expand the palate for whatever reason. And then our best choices would be try to breastfeed if you can. Do tummy time, play games, interact with the child. Use tongue and mouth movements, hold the babies, let them, it seems so obvious, but we're so busy trying to work, trying to do all these things that these babies are suffering because of our busyness.
And even in a pediatric practice, I don't think most of them see babies, but a lot of 3-year-olds have baby siblings, and the mother brings the baby in. And why can't we just take a look and just ask a question? How is the feeding going? Get networked in with your IBCLCs. Get networked in with these people. Have them come in and do a lunch and learn with your office. It's not that hard. People love to bring you sandwiches or whatever. It's harder and harder because not COVID aside, it's harder and harder to get the right food for people for lunch and learn. So a lot of people are just doing learn over lunch. The other thing is that there's a new organization that started this summer called the International Pediatric Orthodontic Society. It is for 0 to 3-year-old children. What are you going to do orthodontically for this kid? I don't know. I would like to learn more, but that's the trend, ladies and gentlemen.
So what are we waiting for? By 3 years old, 80% of the brain is already developed. By 5 years old, 75% of the face is already developed. That's why we're talking about the first 1,000 days of life. We're talking about the first 5 years. That's why this early intervention is super important. And then by the time they're 14, 15, sometimes a little younger, sometimes a little older, the palatal suture closes. So that window for expansion is already closed. Okay, so then we have to do surgical expansions and think of other options for these patients to expand that palate. Why not use the tongue?
Yeah.
What a concept.
I was talking to my what does she call herself? My massage person. Oh, I don't know. It'll come to me in a second. And we were talking about TMJ, and I was like, we were talking this way and that way, and she does all this stuff. And she goes, well, what about the appliances? When do you start using the appliances? I'm like, the tongue is the appliance. Right. It's so foreign. Everybody wants a pill. Everybody wants a thingamajobber.
Yep.
So we have a lot of craniofacial dysmorphology, abnormal facial growth that comes from orofacial myofunctional disorders.
So back to mouth breathing. James Nestor covered mouth breathing pretty well in his book, but Dr. Harville did his monkey study where he took 16 or 8 pairs of monkeys, and he put silicone plugs in their noses, and he studied them for 3 years, and he took x-rays and cephalograms and stuff, and the result were that notching in the upper lip, the steep mandibular angle plane, increased facial height, which is the long, narrow face, and the neuromuscular imbalance between the neck and the facial muscles in the monkeys. And even some of them got really sick, and some of them died. And this other picture here, I'm sure you can identify people in your life or that you've seen with the picture where their eyes are just kind of sunken in. They have that crooked nose, receded chin. Those patients have those small airways. They have that long, narrow face, and you see them also with bad posture. So here's our list of all our malocclusions. We've already talked a lot about this. The bottom one, limited tongue space. That's because the arches are narrow and the tongue seems like it's too big. Can't fit in the palate.
And that's why this is malocclusion in a 5-year-old. Dr. Boyd, the pediatric dentist in Chicago and the co-president of this international pediatric orthodontic group, says you should be able to put a nickel between the teeth of a 5-year-old. A nickel. Have you ever seen that? A nickel. I try to go for a dime, right? I want to be able to get like toothbrush bristles through there, and these parents are like, oh, their teeth are so tight. And I'm like, that's because their tongue is too low. And, you know, now you have a whole kind of a different conversation with them.
It's funny, we were watching on TV last night, Toddlers and Tiaras. They have
Oh.
what they were before and what they were after. Just, sorry, that was after 90 Day Fiance. But all these little beautiful children have no spaces in between their teeth. So then I was interested to see what they grew up as, and they showed them 14, 15 years old with these tiny, tiny mouths. And some of them had no room for their cuspids to come in. So it's true. It is true. So another thing we see is our patients have difficulty with chewing and swallowing. A lot of patients with sleep apnea and snoring issues have problems with sleeping and swallowing. This list here, the messy eaters, the slow, the last kid at the table to finish their food, the chewing with the mouth open. The parents love when we do myofunctional therapy, because we teach them how to chew with their lips closed, to chew their food properly for a long time. And it helps with digestion and that kind of thing. So
I've had patients referred to me who couldn't take impressions or couldn't have impressions taken on them. That's been pretty successful. We didn't even touch on thumb sucking. So we'll save that for a different day.
So we're trying, yes, and the gaggers. We're looking at sleep problems here too. So any children, you can ask the parent, do they grind their teeth? Are they grumpy? Bedwetting. Latent bedwetting is a symptom or a sign of sleep disordered breathing. The brain is taking all the energy and the oxygen, and the other organs, the bladder is not able to work because of the sleep apnea. Does the child sleep in odd positions? Is there snoring or loud breathing? Are they up every night with nightmares, constantly waking up? Shirley's going to give you, I think she already sent you a sleep screener that you can print out and use in your operatory or add to your health history if you would like. There are many, many different kinds. There's the PSQ, sleep inventory, the bears.
I like the disturbed sleep one that I sent you because it has those gray areas. And when the child gets a yes in any of those gray areas, those are intended to stimulate a referral to an ENT.
So orofacial myofunctional disorders go hand in hand with airway, if you guys haven't figured that out yet. It's so much that the ADA and the AAPD policy statement in 2017 said, in children, screening through history and clinical examination may identify the signs and symptoms of deficient growth and development, other risk factors that may lead to airway issues. This is what we're talking about here, you guys. Your doctors or you got to be screening for this stuff. And, these are a couple of my patients also. It can myofunctional therapy can greatly improve the quality of people's lives.
So now you know why, and you know what you should be looking at and how to see it. Now, how would you refer? So if you can't find someone close by to you to refer to just directly, both Suzanne and I do very extensive exams and appointments all online. So even though I'm in Wisconsin and she's in California, we would see any patient from anywhere. I've given you in your little handout there that I sent the other day, and again this morning, a little chair side screener for you to kind of have nearby. You can print that out, or you can just memorize it if you have one of those really super memories, and just look at, are you putting a tonsil score in your patient's notes? Large tonsils would indicate mouth breathing. An enlarged uvula would indicate snoring, same as a low soft palate, which is really hard to really discern. Gag reflex would indicate a primitive reflex, and so on down the line. So this is a real
That is great,
bare
Shirley.
naked one. And then there's even smaller one that I attached with today's email that Suzanne had put together. She
So
also, has this going. That's pretty cool.
So I just put this together just off the top of my head, just trying to figure out, okay, what's a quick, super quick screening for dental hygienists or dentists to do? A, B, C, T, R. A, archway. Look at the arches and the airway and the soft palate. B, breathing. Are they mouth or nose breathers? C, is there crowding? Is there room for all the teeth coming in? T, tongue. Check for a tongue tie. And R, refer.
You have a copy of my referral form and you have a copy of Suzanne's. Mine is an answer to my location because nobody knows what myofunctional therapy is here. In California, at least they've heard of it. So I put on here the stages of action. What do we exactly do? This is the patient half here on the right, what it is that you are suggesting that we take a look at. And then on the left-hand side is what you scan in and send to us so that we have the information we need to contact the patient. What happens with these referral sheets is that they float around the car until somebody vacuums it up. And so by us calling them, we're able to answer a lot of questions and get to the real meat of what they have going for them. And we can say, Dr. So-and-so said that you have these things going. So that's how we designed ours. This is another really good option to have as a chairside little checkoff sheet. Includes pacifier stuff on here and drooling and gagging and all of this whole kind of thing.
Yeah, so this is my information as well. If you want to shoot me an email or look at my website or call me, text me, happy to answer questions.
Now for the big reveal here for the people that sent us pictures, some of you did, for a massive saving on your initial assessment is $20. And either Suzanne or I will spend an hour with you to kind of look you over, you or your child, and then develop a treatment plan or make suggestions on what you can do for your own condition.
It's really great because you learn so much about your mouth, even though you're a dental person or a medical person. There's so much, it's in so much detail, and you learn things start to make sense and connect the dots and, the missing puzzle pieces.
We're going to go over those pictures that you sent, and we'll just send you a little, couple sentences about what we see. But Philip will be connecting with you to see if you'd like to have a more full assessment. You'll be taking some photos at home and you'll be sending them in. This is how we do all of our virtual appointments. Patients take pictures of their own mouths. Sometimes they can't. So I'm also looking for hygienists that are interested in taking myofunctional disorder photos. We'll tell you, we'll answer the questions in a minute. So there's that. And really this pill thing just has to end. We want children to not chew pills. We want them to chew actual food. And that is a really gigantic missing piece to this whole thing. So we talked pretty much about all of these kinds of things today. As we're wrapping up here, we're going to go over the questions that have been coming in. And I'd like to let you know that Katie Leva, who is one of our Primal Air therapists who deals with the littles, the 5 and unders, is going to be having a first 1,000 days course coming up. So I have everybody's email address, so I'll just send you an update when we have a date.
Nice.
So let's see, I think that's it. Oop, yep. Let's go back here and I will expand the questions here. Kyle says she loves taking photos. Yay. I submitted to Under One Roof to have a class on taking photographs for myofunctional therapy. So that's good. And then let's see, Nancy, can you say what pictures I need again? I will answer that in a minute. Do you know, Suzanne, of any resources for low-income patients?
I don't, other than for myofunctional therapy, there are, simple exercises online that I refer. Me in my own practice, I see 2 patients a year at no charge or very, very reduced charge because there's definitely a need, and it's just what I can do in my practice. And but they'll have to look for videos. Dr. Yoon has videos, very, very basic, but it's better than nothing.
Dr. Who?
Dr. Audrey Yoon. She's from Los Angeles. She's a pediatric.
Yoon, right?
Yoon, Audrey Yoon. So she's got YouTube videos online for just very, very basic myofunctional therapy. Her whole practice is the whole extreme, and there are patients that cannot afford myofunctional therapy.
There's a pediatric dental hygienist who sees 1-year-old kids, so that's awesome. There are appliances or gadgets or whatever you want to call it for that age group, if you can get that caught. We're wondering.
Reach out if you want to know about any appliances for the younger ones.
We don't have any results yet from Brazil making those changes. So we're waiting to hear back from how they're going to be doing that. Everybody wants a recording. I don't know what we're going to do about that, but we'll let you know. Can you see a deviated septum on a Panorex?
Oh, I don't know. Can you, Shirley?
I'm not good at panoramic x-rays, so I don't know.
That's a good question.
It seems like you should be able to, but sometimes it's just so subtle.
Right. But an ENT evaluation can evaluate the septum, the tonsils and adnoids. And so that's really helpful.
Sweet. So I'm going to dig up my little pictures here that I use for, keep talking and I'll just drag those up real fast.
So it seems like most kids have large tonsils. Well, if the lips are closed and they're breathing through their nose, less likely to have large tonsils. If there are 3 or 4 and they're blocking the airway, that is a problem. So a lot of times you can see if you can teach them to breathe through their nose fully, which is what we do, and see maybe the tonsils will shrink. We also, have an anti-inflammatory diet, no milk and dairy stuff for inflammation, to get them to be able to breathe through the nose better. So it's like there are a lot of moving parts there, for sure.
So I'd like to have a couple of thoughts about the tonsils, because everybody wants the tonsils out. And Kyle asked about too many tongue tie releases. One about the tonsils. Tonsils grow faster than the rest of the body starting at about age 5. So it's a natural occurrence that the tonsils are bigger, but that may stimulate nasal breathing or stimulate mouth breathing. So it may be like a bad circle of events. And so when the child eventually does grow big enough, they've got the habit of mouth breathing, and the tonsils are big because they haven't had purified air going past them. And the tongue tie releases are only so high because we know more about the effects of a tongue tie than we ever have. And more people are willing to just go for it because it's just so miserable to live with a tongue tie. Just some of the stories of these people that have these releases is just incredible. If you want to see a bunch of videos on that, you can go to YouTube and look up Breathe Institute.
And I'm about 2 hours away from Los Angeles, and I go with my patients, and the change is profound. the change is profound. I wouldn't believe it if I wasn't sitting in the operatory myself. It's just a letdown, a relief of neck pain. They just can breathe better. The sinuses open up. It's just, like I said, I wouldn't believe it if I wasn't sitting there in the room with the patient.
Yeah, it's really amazing. So these are the pictures that we take at Primal Air. We take about 26 pictures as initial photos.
Here,
Go ahead.
I was gonna say there was the range of motion measurements. Yeah, with the ruler. Mm-hmm. That's how we measure open mouth, tongue up on the incisive papilla. A lot of times we see a lot of buccal ties as well that are holding down the arch from growing.
So this is what I meant by this inappropriate attachment. So this is the same girl as we saw earlier, the arched palate. Her tongue is tied way over here. It should be about here where you see the salivary ducts.
Also, there's the one that's called the Eiffel Tower. Looks like an Eiffel Tower.
Mm-hmm. So yeah, those are the pictures that we ask our patients to send in, and it'd be sweet if we could just say, go over there to Donna Hygienist and have her take these series of pictures. So there is a code for photos in case you care about that. And I think that's it. Let's see.
Yeah, so Kyle says the news is saying that too many tongue ties are being done. That was what her comment was. And, you know, it's just becoming, because we know so much more about the problems that tongue tie cause, that is why it's being recommended. I'm telling you guys, I have 5 patients in the last couple of years. Their parents are dentists, and they had no idea that the tongue tie was causing all these problems in their own child.
Right.
So
they don't know. I talked to an ENT this week about a patient that we had sent him, and he's like, well, my own daughter's tongue tie is worse than this, and I won't release hers. And then he started going on about the studies are unclear, and there's a lot of problems if you do a tongue tie release, and you know, stuff like that. And then he said, then I said to him, are these reports on patients who have had myofunctional therapy to prehabilitate and rehabilitate the tongue before and after the release? And there, you know, that's the magic right there. It's the magic. Kyle is also concerned that not enough people will, or too many people will read these reports and say, see, and we do run into that. The mother will be like so in tune with everything, and then the dad's like, no, we're not doing that. Look, it says right here in the news, we don't need to do it. So, I mean, all we can do is what we can do. It's the same with whatever things cost. If we can't charge enough, then we can't stay open. And if we can't stay open, then there's nobody. And that's one of the reasons why I started Primal Air the way that I did, was so that we could have more of these hygienists that can't seem to get their practice up and going. Suzanne was really amazing. I saw her office, and it's beautiful. It's in a nice part of town. You know, not everybody is good at doing that. So if we can help hygienists start to see patients and see patients tandemly with people that have done things before, that's what we're doing here at Primal Air. And not every hygienist needs to be a myofunctional therapist. We just need people to recognize it and send them along.
Yeah.
So Diana, you have your hand up. Did you want to say something? Mrs. Vacation? Oh, nope,
No,
sorry. All right. Well, thank you everybody for joining us today. Thank you for the swell comments and for your attention. Please spread the word. We need to attach these issues to more and more people. And it's been awesome. So thank you very much.
Thank you. Reach out to us. We want to hear from you. Thank you.